Welcome back to No More Cavities. Today we will be discussing injuries to permanent dentition. So the first injury that we will be discussing is enamel infarction. We have already discussed what is enamel infarction. It's simply a crack in a tooth, a simple crack in a tooth. So what we will do for an enamel infarction? We will do nothing. We will just keep the tooth for review. We will just review it because it is simple crack. The second one is enamel fracture. What we will do for enamel fracture, and what is enamel fracture? It is a loss of tooth substance. It is loss of tooth substance in enamel. We will do according to the situation. We have three options for enamel fracture. The first one is if there is aesthetic concern. If there is any type of aesthetic concern, we will go for restoration. If there are rough edges, we will smoothen the edges, as we discussed in primary dentition, that if there are rough edges, if there is enamel fracture, which means loss of the tooth substance in enamel, and there are rough edges, we will smoothen the tooth surface. And if there is mobility, what we will do? We will go for splinting. We will discuss splinting in further lectures at what is splinting. So for the enamel infarction, we will just go for review. For enamel fracture, we have three possibilities. Depending on condition, we will go for restoration if there are aesthetic concern. We will go for smoothing if there are rough edges, and we will go for splinting if there is mobility. Then comes the enamel dentine fracture. Enamel dentine fracture. We have already discussed that we will divide the enamel dentine fracture on the basis of pulp exposure. It will be complicated. It will be uncomplicated. What is complicated? If there is involvement of the pulp along with enamel and dentine, and uncomplicated, that means there is no involvement of the pulp. So depending on the, first we will discuss the uncomplicated type of the fracture. In uncomplicated type of fracture, we have three options. We will go for immediate treatment, all we are discussing is uncomplicated fracture. Immediate treatment, emergency treatment, and intermediate treatment. So for the immediate treatment, we have to protect the pulp against the thermal osmotic irritation. And in emergency treatment, we have three options. The first is composite, because pulp is not involved, and if there is loss of the enamel and dentine, you can restore it with composite or compomer. This is first option. You will go for composite or compomer. Then you will go with GIC within an orthodontic band. What we will do, we will put GIC along with an orthodontic band. This is the second option. The first was composite or compomer. The second is GIC along with the orthodontic band. And if there is insufficient enamel, we will go for preformed metal crown. Preformed metal crown. So first is immediate treatment, which we will do to protect the pulp against thermal osmotic irritation. The second treatment is emergency treatment. In emergency treatment, we will have three options. The first is composite or compomer. The second is GIC with orthodontic band. The third is preformed metal crown. These all are emergency treatment. Then comes the intermediate treatment. Intermediate treatment is further divided into two. There are two options in intermediate treatment. The first is the resin bonded composite. And the second is the reattachment. Reattachment. If there is loss of enamel and there is fragment, you have the fragment with yourself, then you can reattach it. So for the intermediate treatment, we will go for resin bonded composite, and the second type of option is reattachment. Reattachment is further divided into two options that what we have to consider. For reattachment, again we divide it in two. Reattachment. So the treatment will be based upon the fracture line. If the fracture line is close to pulp or the fracture line not close to pulp. Okay, so for reattachment, if you have the fragment of the tooth and you are going for reattachment, you will consider that the fracture line is close to the pulp or the fracture line is not close to the pulp. Consider this as a tooth and this as a pulp. So fracture line is close to the pulp or the fracture line close to the pulp and fracture line not close to the pulp. So the treatment will be based upon the position of the fracture line. If the fracture line is close, first we will discuss not close to the pulp. If the fracture line is not close to the pulp, what we will do? We will just immediately attach the fragment. What we will do? We will just immediately attach the fragment. But what we will do if the fracture line is close to the pulp? We will go for, if the fracture line is close to the pulp and the dentine is exposed, we will put calcium hydroxide or calcium silicate. Calcium hydroxide or calcium silicate over the exposed dentine. Over the exposed dentine for a month. This is for a month. For a month. What we will do if the fracture, if there is enamel and dentine fracture, uncomplicated fracture, and we have a fragment with ourselves, we will go for reattachment. If the fracture line is close to the pulp, we will place calcium hydroxide or calcium silicate over the exposed dentine for a month. Then we will store the fragment in saline, and this saline needs to be renewed weekly. You have to weekly change the saline. So we will put the fragment in saline, and we will put calcium hydroxide and calcium silicate over the exposed dentine for a month. Then we will start the reattachment process. And what's the process? First of all, you will check the fit of the fragment. Check the fit of the fragment. Just like we check the fit of our clothes before putting them on, we will check the fit of the fragment. We will check the fit, plus we will check the vitality of the fragment, if it is vital or not. Then we will clean the tooth and the fragment with pumice water slurry. Pumice water slurry. Then we will isolate the tooth. We will attach a sticky wax on the fragment. Why? For proper handling. We will attach, suppose this is a fragment, and we will attach the wax so we can handle it from wax. Then we will etch enamel. As we know, we etch enamel for 30 seconds. Then we will wash it, dry it for 15 seconds, and for 30 seconds. Then we will apply bonding agent for 10 seconds. And we will place appropriate shade of composite and position the fragment. And remove the excess with sandpaper. Remove the excess with sandpaper. So this was the process of reattachment. At first you have to check the fit of the fragment and vitality, clean the fragment with pumice water slurry, isolate the tooth, attach the sticky wax on fragment for proper handling, etch the enamel for 30 seconds, wash it and dry it for 15 seconds for both, then apply the bonding agent for 10 seconds and place the appropriate shade of composite and position the fragment and remove the excess material. This was the process for reattachment and the enamel dentine uncomplicated type of the fracture. Now we will discuss the enamel dentine complicated type of the fracture. Means the pulp is involved. The options for enamel dentine complicated fracture are vital pulp therapy, and non-vital pulp therapy. Vital pulp therapy again include pulp capping, and pulpotomy. The pulpotomy is further divided into partial pulpotomy and complete pulpotomy. What do you mean by partial and complete? Suppose that this is our tooth and this is our root and this is our whole pulp. So as we know that the pulp is divided into coronal pulp and radicular pulp. Coronal pulp and radicular pulp. If we are removing the pulp, coronal pulp and radicular pulp both, if we are removing both of them, then it's complete pulpotomy. But if we are removing, if we are removing the whole coronal pulp, then it is complete pulpotomy. And if we are removing the half of the coronal pulp, like we have removed this pulp and still some coronal pulp is remaining, then this is the partial pulpotomy. So the pulpotomy is divided as partial pulpotomy and complete pulpotomy. Partial pulpotomy means that you have removed half of the coronal pulp, and complete pulpotomy means you have removed fully the coronal pulp. So vital therapy includes pulp capping and pulpotomy, which is further divided into partial and complete. The non-vital means pulpectomy. Non-vital involve pulpectomy, means removal of the whole pulp, coronal pulp as well as radicular pulp. So removal of the whole pulp is pulpectomy, removal of the whole coronal pulp is complete pulpectomy, and removal of the half of the coronal pulp is partial pulpectomy. So first we will discuss pulp capping, which is vital pulp therapy. So vital pulp therapy. Vital pulp therapy, first we will discuss vital pulp therapy. Vital pulp therapy means that the pulp is still alive. It is not dead. So vital pulp therapy is including pulp capping and pulpotomy. Then what is the difference between these two if these both are vital? So pulp capping is done when the exposure of the trauma is within 24 hours. And if the exposure of the trauma have crossed more than 24 hours, then we will go for pulpotomy. So this is the major difference between the pulp capping and pulpotomy. It is time difference, but both are vital pulp therapy. First we will discuss pulp capping. So for pulp capping, when we do pulp capping, when the trauma exposure is within 24 hours. For pulp capping, first we have to isolate the tooth. What is the process of the pulp capping? We have to isolate the tooth. We have controlled bleeding with cotton pellet. And this cotton pellet must be moistened with saline or sodium hypochlorite. Okay, so the first what we will do in pulp capping, we will isolate the tooth, we will control the bleeding with the cotton pellet, which should be moistened with saline or sodium hypochlorite. We should not use the 3-in-1 syringe. The syringe which we use in OPDs for air and water, we should avoid to use the syringe because it will induce microorganisms into the pulp. Okay, we have isolated our tooth, we have controlled the bleeding with cotton pellet which was moistened with saline and sodium hypochlorite, and we have used 3-in-1 syringe. Now what we will do, first we will make a layer of calcium hydroxide. Which calcium hydroxide? Setting calcium hydroxide. Okay, setting calcium hydroxide or calcium silicate, you can use any of them. After controlling the bleeding, you will first make a layer of calcium hydroxide, then second layer will be of adhesive material. Adhesive material like compomer. Then the third layer, you can delay or bend, you can delay the third layer, which is definitive restoration. Definitive restoration. So this is the whole process of pulp capping. What is pulp capping? It is a process of vital pulp therapy which we perform when our pulp is still alive and the exposure of the trauma is within 24 hours. First, we will isolate. We will control the bleeding with the cotton pellet. We will not use 3-in-1 syringe. Then we will form a layer of calcium hydroxide, setting calcium hydroxide or calcium silicate. We will go for adhesive material and then definitive restoration. This is the whole process. After performing the vital therapy, you have to review the tooth for first 3 months, then 6 months, then 4 years. In radiograph, what we have to examine, we have to see that the root, actually it is immature tooth now, so the root is growing in length and it is narrowing. The apex should narrow. It should grow in length plus the apex should be narrow. It means that the tooth is maturing. It is alive. If it is not growing and not maturing, it means the pulp is dead. So after performing pulp capping procedure, you have to examine the tooth for 3 months, then 6 months and 4 years. Okay, what we will have to examine on radiograph, that the tooth is growing in length and it is narrowing. The apex is closing. It means that the tooth is alive, it is not dead. So this is the whole process of the pulp capping. What are advantages of the pulp capping? It will preserve the remaining pulp and it will deposit the reparative dentine. Then the second procedure of vital pulp therapy is pulpotomy. Then comes the second procedure of vital therapy. What is pulpotomy? It means removal of the half pulp, which will be partial, which will be complete. Coronal pulp, if it is removed completely, it is complete pulpotomy. If the coronal pulp is removed half, then it is partial pulpotomy. Pulpotomy is performed when the exposure is more than 24 hours. The exposure is trauma have occurred and the patient is coming after 24 hours, then you will perform pulpotomy. But trauma have occurred and the patient is coming within 24 hours, we will go for pulp capping. So pulpotomy, why are we performing pulpotomy? To preserve. What are the advantages? That we are preserving the radicular pulp. We are preserving the radicular pulp and we are removing the coronal pulp. But what we will do if we are preserving the radicular pulp? What are the advantages of preserving the radicular pulp? It will allow apical root development. It will allow further apical root development that we discussed in pulp capping, that the tooth should narrow and it should grow. The apex should be closed and it should grow. So if we are preserving radicular pulp, it will allow the apical root development and the apex will close. The second advantage is, first is allow apical root development and the second is it will deposit the dentine. What it will do if the pulp is present, obviously what is the function of the pulp? it deposits the dentine, it nourishes the dentine. So if the radicular pulp is present, it will allow the apical root development and it will deposit the dentine. So how much pulp should we remove? Like we will how we can know that we have to go for complete pulpotomy or partial pulpotomy? It depends on the contamination of the pulp. Now we will discuss the procedure of pulpotomy. First we will go for LA because the pulp is exposed and we don't want a patient to experience the pain. So we will go for first LA, then rubber dam isolation, then removal of the pulp. Removal of the pulp will be with high speed handpiece. And the diamond burr. Then it is depending on you that what you are performing, partial pulpotomy or complete pulpotomy, but you have to go for high speed handpiece and the diamond burr. First you will go for LA, then rubber dam, then removal of the pulp. If there is excessive bleeding, you are removing the pulp and the bleeding is massive, it is not in your control, or there is no bleeding at all, it means you have to remove the further pulp. If there is excessive bleeding or there is no bleeding at all, it means still you haven't reached to the fresh pulp, the healthy pulp. For healthy pulp, what is the sign of that you have reached the healthy pulp? The fresh bleeding. There will be fresh bleeding, but not massive. But if there is massive bleeding or no bleeding at all, it means you have to further remove the pulp. You have performed the procedure of LA, you have isolated the tooth, you have removed the pulp. What we will do? Now we will rinse the wound. With saline or same sodium hypochlorite. Then we will go for calcium hydroxide or calcium silicate dressing, non-setting calcium hydroxide or calcium silicate dressing. Then we will go for hard cement. And after that we will go for final adhesive restoration to seal it properly. First we will go for calcium hydroxide non-setting, then we will go for hard cement, and then we will go for final restoration which will seal it properly. So this was all about vital pulp therapy. Thank you for watching.